As previously we discussed the bacterial corneal ulcer and fungal keratitis, okay? If those conditions are not managed properly and timely, what will happen? They will cause complications. Now we will discuss those complications, okay? So the complications of corneal ulcer. The first one is iridocyclitis. Iridocyclitis is when there is the ulcer and inflammatory infiltrate, what will happen? If the inflammation is severe, then the cytokines and the toxin, they will comes to the interior chamber, and these cytokines and toxin will cause the inflammation of iris and ciliary body, okay? So the iris and ciliary body will be inflamed, which is called iridocyclitis. In turn, this iridocyclitis, it will release inflammatory infiltrate into the interior chamber. And this inflammatory infiltrate in the interior chamber, this is called hypopyon, which can also block the trabecular meshwork for the aqueous humor and causes secondary glaucoma. Okay, so it will also cause secondary glaucoma. Now, dysmetocele. Dysmetocele is when the ulcer is so much severe that it has involved the entire thickness of the cornea and has reached up to the descemet membrane. Okay, the ulcer has now so much deepened that it has reached to the descemet membrane. What will happen? This descemet membrane, this will bulge out. Which is called dysmetocele. Okay, so the descemet membrane has been bulged out to the outside of the cornea, which is called dysmetocele. Now, if this dysmetocele is not managed in this stage, what will happen? There will be perforation in this dysmetocele and in the entire thickness of the cornea. This is called, now the outside environment and the aqueous humor, they are connected. This is called perforated corneal ulcer. Okay, now the entire thickness of the cornea is damaged, and now there is a direct connection between the internal environment and external environment. Okay, so perforated corneal ulcer has now in turn, it has more serious complications. Okay, iris prolapse. So the perforated corneal ulcer will cause immediate iris prolapse. Whenever there is the defect in the cornea, when there is the hole and defect in the cornea, what will happen? The iris will immediately come to that place in order to seal off the perforations. Okay, so in this, iris will try to plug in and to seal the perforation, and it will also come to the outside environment, which is called iris prolapse. Okay, and this iris prolapse, we know that the lens which is kept in place by the zonules. Okay, these are the fibers which has kept the lens in place. When the iris has been prolapsed, then it will also stretches the zonules. When the zonules are stretched, then it can rupture and it can cause the lens to come into the interior chamber, which is, if the lens is completely dislocated, it is called interior dislocation, and if it is partially dislocated, it is called subluxation of the lens. So the lens can be dislocated into the interior chamber due to the stretching and rupturing of the zonules. Now if this lens remains in contact with this perforation for a longer period of time, then it can also cause the opacity of the lens. The lens will become hazy and cloudy, which is called cataract. So it can also causes the cataract. So because of the iris prolapse, there is a high chance of dislocation of the lens and cataract. Okay, so these were the in-turn complication of the perforated corneal ulcer. Plus this perforated corneal ulcer can cause, as now the external and internal environment are connected, so the microbes can come into the eye. Okay, directly, and will cause the inflammation of the interior chambers and the posterior chambers. Okay, so this inflammation of intraocular cavities, this is called endophthalmitis. which is a serious complication, is because this endophthalmitis can progresses to panophthalmitis, in which there will be the entire eye layers will be inflamed. So the eye layers, the retina, the choroid, the sclera will be inflamed, which is called panophthalmitis, and it is a serious complication. Okay. Intraocular hemorrhage is whenever there is the perforation. We know that when there is perforation, what will happen? The perforation will cause the intraocular pressure to drop down. When the intraocular pressure is reduced, what will happen? For a longer period of time, then there can be the hemorrhage. Okay, there can be the suprachoroidal hemorrhage and vitreous hemorrhage. So there is the risk of hemorrhages in the suprachoroidal region and in the vitreous. Okay, because of the reduction of intraocular pressure suddenly, and this sudden reduction of intraocular pressure can also cause retinal detachment, in which the retina will be separated, from the other layers, which is called retinal detachment. Okay, so the sudden reduction of the intraocular pressure due to the perforation will cause intraocular hemorrhages and retinal detachments. Okay, so these are the serious complications of perforated corneal ulcer. Corneal obesities. So I told you before in the lectures of bacterial corneal ulcer that when there is the healing stage, what will happen? In the healing stage, the keratocytes, these keratocytes will cause the deposition of collagen fibrils in order to heal the stroma. Okay, so if the inflammation is severe, if the ulcer is severe, if the inflammation is chronic, what will happen? These deposition of collagen fibrils will be deranged. Means that the deposition will be non-oriented and irregular. This non-oriented and irregular deposition of collagen fibrils, it will cause cloudy and hazy cornea, which is called corneal obesities. Okay, it can be nebula, macula, leukemia, and ectatic cornea. The nebula this obesity involves only the interior superficial part of the stroma, and it is non-significant, means it does not have so much severe effect on the vision. So it is a non-significant superficial scar. The macula is a semi-dense scar which involves the interior half of the stroma. Okay, so it will cause deterioration in the vision. The leukemia is a dense white corneal opacity which will involve the entire thickness of the stroma. Okay, the entire thickness, there will be the entirely white cornea. Okay, there will be the entire cornea will become white. Okay, and this is a dense corneal opacity. This is leukemia. Now the last one is the ectatic cornea. Ectatic cornea, it is the cornea, although it is a healed cornea, but the cornea is so much thinned by the destruction that it is a thin healed cornea. Okay, it is a thin healed cornea which bulges out under normal or increased intraocular pressure. Okay, it will bulge out. It is a thin healed cornea which bulge out under normal or increased intraocular pressure. Like if I like this, okay, it will bulges out outside. So this is the ectatic cornea. So these were the complications of corneal ulcer. Now how can we treat? As if the desmetocele and perforated corneal ulcer are so dangerous, so we should treat them, right? Okay, so how can we treat them? We can treat the condition, the desmetocele can be treated as I told you before, that these complications can be caused by bacterial corneal ulcer, by fungal disease, and by viral disease. but the incidence of these complications, it is more in bacterial corneal ulcer, okay? So if it is bacterial, we will give intense antibiotic therapy, okay? Intense antibiotic therapy will be given. The treatment of dysmetocele, okay? So intense antibiotic therapy will be given. We will control the glaucoma, okay, and we will control the pain. As the pain should be controlled, if we control the glaucoma, the pain will automatically be controlled, because the pain is due to the glaucoma and the iridocyclitis. So if we control the glaucoma, the pain will be controlled. We know that this is the bulging out, okay? Dysmetocele is the bulging out of the desmet membrane. So this bulging out desmet membrane, we can also do conjunctival flap transplantation. If we place conjunctival flap on this bulges out desmetocele, okay, what will happen? It will reduce the pressure. The underlying pressure will be reduced, and there is the chance of rupturing will be reduced. Okay, so conjunctival flap can be transplanted, can be placed. Amniotic membrane can be placed. Amniotic membrane can be placed in two places. We can place the amniotic membrane right over here, okay, in the defective area to cover the defective area, and also we can some of the amniotic membrane will be placed on the surface like conjunctival flap, okay. So amniotic membrane transplantation can be done. We can use growth factors. We can take the growth factors from the serum and from the cord, okay, umbilical cord. So conjunctival flap, amniotic membrane, growth factors, pressure bandage contact lenses can be used. And the final remedy is the keratoplasty. If by all these procedures, by all these treatments, if the dysmetocele is still not managed, so what will we do? We will transplant the entire cornea of the patient, or we will transplant only the layers, the defective layers, okay? This is called keratoplasty. So the final remedy is the keratoplasty. Now if the dysmetocele is perforated, then how can we treat? Now if this is the perforated corneal ulcer, it is treated like the dysmetocele, but we can also get some additional drugs like anticollagenase can be given, tetracycline, and plus tissue adhesive glue can be given. Tissue adhesive glue and tetracycline anticollagenase can be given with all these treatments of dysmetocele. So this is the treatment for perforated corneal ulcer. And like in dysmetocele, the final remedy is keratoplasty. So the keratoplasty is the last resort with us in any corneal problem, okay? So these were the complications of corneal ulcer. I also have prepared notes. I will give the link in the description. You can go through the notes and can learn more. Thank you for watching the video.